My name is Ryan Clary, and I am the Executive Director of the National Viral Hepatitis Roundtable. NVHR is a broad coalition working to fight and ultimately end the hepatitis B and C epidemics in the United States. For those of you who are not familiar with our work, I encourage you to visit our website at www.nvhr.org to learn more about our programmatic and public policy activities. It's my pleasure today to moderate today's webinar and to introduce our stellar panelists. As you all undoubtedly know, we are in a very challenging hepatitis C treatment access environment with significant and harmful restrictions and barriers that are keeping many people living with hepatitis C from being cured. Many of us are advocating at the federal and state levels to fight these restrictions and to expand access. At the same time, many medical, health, and service providers around the country are working tirelessly to advocate on behalf of their patients and clients who want to be cured. Today we will hear from 3 such individuals who provide hepatitis C care and services on a daily basis. They will share their strategies and ideas on how they have been able to help their patients and clients access life-saving treatment. I will introduce each speaker before their presentation. Following all of the presentations, we will have time for questions and answers. You can submit a question at any time during the presentations by typing it into the chat box. You can also email questions to Tina Broder, who is NVHR Senior Program Manager, at tbroder@nvhr.org. That's tbroder@nvhr.org. Also, this webinar is being recorded, and a recording of the webinar and the slides will be available on NVHR's website. We will also send a link to all registered participants. Our first panelist today is Dr. Stacy Truskin, Assistant Professor, Division of Infectious Diseases and HIV Medicine at Drexel University College of Medicine and co-chair of the Hepatitis C Allies of Philadelphia, HepCap, in Philadelphia, Pennsylvania. Dr. Truskin initially developed her interest in hepatitis C in 1999 while pursuing her MPH at Yale University. Her work has involved evaluating the hepatitis C reporting databases for the state of New Jersey and Connecticut and identifying the clusters of disease within the state. In 2001, she enrolled in the MD-PhD program at Robert Wood Johnson Medical School and University of Medicine and Dentistry of New Jersey School of Public Health. She continued to pursue her interest in hepatitis C and returned to Philadelphia to conduct her dissertation work. Her research focused on identifying barriers to screening and testing for hepatitis C in minority populations. After completing her doctorate degrees in 2007, she went to the Hospital of the University of Pennsylvania for internal medicine residency and fellowship in infectious diseases. She used her fellowship to develop clinical expertise in the areas of hepatitis C and HIV. In July 2012, Dr. Truskin joined the faculty at Drexel University School of Medicine, where she continues to pursue her clinical and research interests in hepatitis C, with a focus on developing effective models for hepatitis C testing and linkage to care. Since 2011, Dr. Truskin has served as the community co-chair of the Hepatitis C Allies of Philadelphia Coalition. In this role, she provides leadership to over 300 community partners representing over 30 agencies who are collaborating to improve the delivery of hepatitis C prevention, testing, care, and treatment in Philadelphia. Dr. Truskin?
Thank you, Ryan. I appreciate that introduction. I'm having a little bit of technical difficulty. I think when you guys switched over the screen, I lost the screen that you guys did. It totally went away. So I don't see my slides up here at all.
Stacy, can you try opening your PowerPoint again? Okay, if not, I can go ahead and show the slides and you can.
I think that's probably better. I'm not seeing, I'm clicking and nothing's coming. How's everybody doing today? Greetings from Philadelphia.
And can you hand it back to me, Stacy, or?
I did.
Okay. Let's try that. All right, sorry about this, everyone. We're a little bit stuck. Okay.
Great. There it is. Okay. So I'm going to give you all a provider's perspective on hepatitis C treatment access. Next slide. So I want to walk you first through what we do at the Partnership Comprehensive Care Practice for the patient's initial visit. So we first want to welcome the patient to the practice. In some cases, our patients have been living with hepatitis C diagnosis for decades, and other patients have recently found out through various testing programs that we are involved in. And they may only now be coming to terms with the fact that they've probably had this infection for a number of years and are quite nervous as to what to do about it moving forward. So we always extend a warm welcome, and we share with patients our philosophy of patient care. And that philosophy really is that everybody deserves a cure. And I lead with that sentiment because what I then share with them is the challenges around access to cure. And of course, we provide careful hepatitis C education. We discuss the natural history, disease transmission, treatment. We always provide harm reduction counseling as well as the possibility of reinfection. And as part of that harm reduction counseling, we really believe that we meet all of our patients where they are right now. And if someone happens to be drinking or happens to be using drugs, we talk about that in detail. We try to quantify exactly how much they're using in a very realistic, open, honest way with no judgment. And then we try to assess if a patient has any readiness to cut back, or if they're interested in entering a treatment program. If they're not, then that's okay. And we try to figure out ways to either keep them safe while they continue the same level of substance use, or we help them come up with a plan to try to cut back a little bit. Within that harm reduction counseling, particularly if this is a patient that continues to use drugs, especially IV drugs, we always discuss the possibility of reinfection. And with that comes a very specific conversation about what their injecting practices are, how they prepare a hit, what they share, what they don't share, and a pretty detailed education with each step that they share with us about the possibility of transmission at each level. So, of course, it's our hope and it's always our recommendation that no drug use and no alcohol use is much better in the short and the long term for their health, but recognizing that some people have a comorbid condition of addiction and are not in a place where they are able, ready, or sometimes willing to stop. We try everything we can to keep them as safe as possible while they continue to use substances. After we've had this thorough conversation with them and we've done a history and physical exam, I'll share with them what I've found. what my impression is, just based on physical, of any significant findings that may be suggestive of cirrhosis. And then we'll discuss the current state of affairs with respect to hepatitis C treatment access in our state, and also, of course, dependent on the type of insurance they have. I do that so that we can basically set their expectations. Many patients will have come in either thinking that interferon is still the mainstay of therapy, or on the other end of the spectrum, hearing that there are now excellent curative therapies and expect me to write them a prescription and send them to the Walgreens up the street. And with both of those two scenarios, it actually requires a fair amount of education and expectation adjustment. So for those patients that have heard about interferon, we talk extensively about the new excellent treatment options that are available, but with that comes the reality that it could take several months to get them treatment, with multiple roadblocks along the way, particularly with respect to the restrictions that are available in the state of Pennsylvania and elsewhere around disease severity. I share all of that with them, and I give them the bad news, good news scenario, that if the bad news may be that they have some substantial liver disease, but the good news will be that we would be able to get medication for them pretty quickly. And conversely, the good news, if they don't have a lot of liver damage, they may not meet the current treatment restriction guidelines that certain insurance companies have into place, and we may need to be creative and fight a little longer to get them medication. But above all, at that initial patient visit, I always pledge our commitment to help secure access to medication. I share with the patient that we will do everything we can to help them obtain the medication that they deserve for a cure. Next slide. So just a little bit more about the restrictive criteria for hepatitis C direct-acting agent approval. So there are really 2 to 3 different types of requirements that we're seeing nationally, and certainly in Pennsylvania where we're located. The first is the sobriety requirement. There tends to be this need for a documented history of abstinence from alcohol and drugs. In some places, it's for at least 6 months. In other places, it's as long as a year. And what many payers require is documentation from the provider that the patient has been clean and sober and substance-free for at least as long as their requisite time period is. And many will require a drug screen and a blood alcohol level during that time. The way that we handle this sobriety requirement in my practice is certainly unique. I tell the patient up front that this is a requirement, that I have to do this, that it has no bearing on whether or not I want to treat the patient, so long as they can take their medication every day. That really is, in my mind, the only really specific criteria for prescribing medication. This has to be a patient that is willing to take the medication daily and can adhere to either a once or twice daily regimen with no missed doses. But oftentimes, the comorbid condition of addiction or substance use, whether it's alcohol or drugs, will not preclude somebody from doing that. And so I share that with my patients, that it's not me that wants to know these things, it's the insurance company. And then I ask them if, in fact, they would be able to provide a clean urine for me today so I could submit the request for prior authorization. If they say no, then I tell them we're not going to obtain a urine today, and that they can let me know when they can either provide a clean urine or a blood alcohol level that I can send in to the insurance company. The next restriction that we see with payers is the disease severity requirement. Many require a METAVIR score of F3 or F4. And for the non-clinicians that are listening in, a score of F3 or F4, F4 correlates with cirrhosis. F3 is pretty extensive fibrosis. So essentially what we're telling our patients is we have to wait until their livers are pretty sick in order to be able to get medication for them. And Further, within that disease severity requirement, some payer systems are really mandating which method can be used for disease staging. Historically, we used to use liver biopsies. Those have largely fallen by the wayside. Many of us are using non-invasive markers for testing, such as FiberSure or HepaScore, and FibroScan is great if you can get it. That's transient elastography, but it is that technology is not always readily accessible. And the last restrictive criteria for drug approval is often the specialist prescriber requirement. Some payer systems will only allow infectious disease providers or hepatologists, gastroenterologists to prescribe these medications. Next slide. So here's the process of approval, and this is animated. So if you could just walk through this with me, as we go. So the first step is to submit a prior authorization. The next step is usually that we get a denial if somebody doesn't meet the criteria. And even in many cases, and I'll share a perfect case in point of this after we finish, is there are some cases where they do meet restriction criteria, but you still get denied based on clerical error, based on one outdated lab, but you do sometimes feel you're in a little bit of a hamster wheel, running, without getting any movement forward. Next. So when you get that denial, you appeal. You may get another denial after that if somebody doesn't meet criteria, another appeal, and then after that denial, you are able to do a peer-to-peer, and that's when one provider calls one of the either PharmDs, nurses, or physicians at the payer program, and you do a peer-to-peer. If that doesn't go the way that you want it to go, next, you then have to submit a grievance. And a grievance is a process where you get 30 days to review, or the insurance company gets 30 days to review the claim, and that's usually a first-level grievance, and then some payer systems also have a second-level grievance, which can add another 30 to 60 days on top of that. Next animation. So this takes approximately 8 hours of staff time per patient. It takes 1 to 4 months to go through this process. Next. And providers cannot do this alone. You need a support staff to be able to do this. You know, we have several hundred patients that are infected with hepatitis C in my practice, and even the ones that qualify, it takes a number of hours to go through this. For the ones that you know up front do not meet the restriction criteria and you're just trying to move through this process that I've laid out for you, you can just expect that your staff and you are going to have to spend a minimum of around 8 hours to get through this process, just so you can try to figure out what other avenues can be taken to get them their medication. Next slide. So when insurance companies will not cover drugs, what are your options? Well, we can wait for new drugs to be approved, but there's no guarantee that those will be covered or the patient will still qualify. We hope that with the addition of new drugs to the marketplace, there'll be additional competition and prices will continue to drop. We've seen in some cases that decreased prices translate to better access, but unfortunately that's not always the case. You can wait until the patient qualifies, and for some that means waiting until they're sober. That doesn't always seem like a fair or an appropriate approach to me. Or you can wait until they get sick, which seems crazy. You can also encourage the patient to take legal action. And then there's the last option, which is what we do in our practice, is once you go through that entire process of denial through grievance, you then apply to patient assistance programs through the makers of the drug to obtain free drug. These are arduous processes. You have to obtain additional financial information from the patient to qualify. You have to have proof that the patient does not qualify for insurance if they're uninsured. It's very challenging to navigate, but we have had some success. Next slide. So I just want to share a couple of examples of some triumphs and some defeats that we have. I'm going to move through these pretty quickly. The first is a 51-year-old African-American woman who comes in for evaluation of hepatitis C after her PCP provided her with routine testing. She has a pretty simple past medical history of just hypertension and anxiety. She has a very remote history of injection drug use, only for about 5 years, but her last drug use was several decades ago in the early 1990s. She got clean after she found out she was pregnant with her son, who is well into his 20s now. She's a non-smoker. She doesn't drink. She's actually a vegetarian and doesn't engage in any substance use whatsoever. She works as a social worker in Children's Protective Services. Next slide. She was found to be genotype 1A. She's treatment naive, and she did not have advanced disease, with her FibroSure being consistent with very early fibrosis. She had private insurance through her job. We did submit a prior authorization, and we got multiple denials. The first one required a psychiatric eval. They noted her history of anxiety, which she only took an anxiolytic maybe once or twice a month for. It wasn't anything that was really out of control. They required that she see a psychiatrist, so we helped set that up for her and had the letter written. And then it took 3.5 months, many phone calls, appeals, to finally get approval. But ironically, through this process, she actually began to suffer from anxiety because she was so worked up that she had hepatitis C, had been living with it for so long. She was completely healthy, at least her perspective was that she never had any medical issues, and being diagnosed with hepatitis C made her very anxious and very concerned. And then with all the denials, she had to start going back to her NA meetings as a result of her increasing anxiety, and she ended up having to take her medication more frequently. Eventually, we did obtain her direct-acting medication, and I'm proud to say that as of her last visit last week, she did achieve an SVR. Next slide. Our second case is a 26-year-old African-American woman who was tested for hepatitis C by her PCP after she was noted to have a transaminitis, or elevated liver enzymes. She has no known risk factors, but she's chronically infected, and she's just been newly diagnosed with type 2 diabetes. She's young, so she hadn't really been to the doctor very often leading up to this. She has no drugs, no alcohol. She's been in a monogamous relationship with a male partner for the last 6 years. She too has private insurance, and she was genotype 1B with a FibroSure of F0, meaning absolutely no fibrosis. Next slide. So she was denied secondary to lack of disease severity, and we had her come back to the clinic every 3 to 4 months to check in. This was right before AbbVie's regimen had come to market, and once it did, Vicirapac was approved, and they entered into the Express Scripts deal, which required that anyone with that pharmacy plan have access to only the Vicirapac, but would not have any restrictions put on them for access. And she completed her treatment 3 weeks ago. Next slide. A 31-year-old African-American male presented after testing positive for HCV at his syringe exchange program. He has no known past medical history. He still injects heroin 1 to 2 times a week. He's also on Suboxone. He does not use any alcohol, but he does smoke cigarette. He's genotype 1A and treatment naive, and his FibroSure showed that he had a little bit of fibrosis at F2. He has a Medicaid HMO, and he was denied based on both his active drug use and his lack of disease severity. Next slide. It took us 6 months to go through the denial process, and we knew early on that we would be denied because he didn't meet the disease severity criteria, and he had come in with a positive urine drug screen. We had 6 months to go through his denial process because they wouldn't let us move through. They kept saying that you were denied because your blood work is old, and his final denial was finally obtained from the insurance company after we brought him back in multiple times to get updated blood work just so he could receive that denial. And then we got multiple denials from Support Path, which is Gilead's patient assistance program, citing drug use. We were in the process of appealing that right now to Support Path. Next slide. And this is the last case. This is a 54-year-old African-American woman with HIV and HCV. She has a very complex past medical history. She's treatment naive but cirrhotic and decompensated. She's got some ascites on exam. Her FiberSure is consistent with that, and she's followed by the transplant physicians as well. She's on methadone. She's a smoker. She doesn't drink. And she hasn't used drugs in over 15 years, and she has a Medicaid HMO. She was denied not for lack of disease severity, but because her insurance company required that we either get a liver biopsy or a fiber scan. Well, she had several medical contraindications to getting a liver biopsy, including low platelets, which puts you at increased risk for bleeding, and we didn't have ready access for a fiber scan. Next slide. And so it took us 6 months to go through the appeals process and obtain a final denial from her Medicaid managed care program. We also applied to Support Path, Gilead's patient assistance program, and we were denied. And the reason they denied us was because the way the language was worded from Keystone, which was her managed care program in Pennsylvania, was because they wouldn't say flat out that she was denied. They said that we hadn't provided them with the appropriate information necessary to make a determination, meaning that we refused to get her a liver biopsy and we didn't have access to a fiber scan. So FiberScan eventually became available to us in Philadelphia a few months later. We used that. We applied to the Medicaid program. They said that at that point we were denied because she needed additional lab work, and it took us eventually 10 months to obtain treatment for this very sick patient and countless hours of provider and staff time. So we were eventually able to get it, and we hope to start her on meds this week. So I think that the lesson learned here is that there are multiple roadblocks and there are challenges in getting patients their medication. It takes a fair number of resources within a clinic to get this done and a lot of time, but when it works, it's pretty exciting. But I think the lack of funding available for some of these support services is definitely a limiting step. Thank you for your attention.
Great. Thanks so much, Dr. Truskin, and thanks for being such a fierce advocate for your patients. Next, I'd like to introduce Karen Arndt, who is a clinical practice specialist at St. Joseph's Center for Liver and Hepatobiliary Disease in Phoenix, Arizona. Ms. Arndt's expertise includes liver and kidney transplant along with liver disease. She has over 12 years experience in liver transplant and 14 years in liver disease. Her responsibilities include the coordination of care for all liver disease patients from hepatitis C, liver cancer, and pre-post liver transplant care. Ms. Arndt has actively participated in liver support groups throughout the Valley. She has assisted patients and families with transportation, patient assistance programs, and applying for foundation and grant funds for hepatitis C treatment, immunosuppression, doctor visits, and lab work. Ms. Arndt received her Bachelor's of Science in Nursing from Fairfield University in Connecticut. She then completed her Master's of Science degree in Nursing at the University of Phoenix in Arizona. Ms. Arndt?
I'm on a conference call. Okay. Thank you for the nice introduction. Hello, can you hear me?
Yes, we can hear you.
Okay.
Slides up.
Thank you for the nice introduction. It's been a pleasure to provide my insight to this very challenging field that we're going through right now. So I'm sorry, I cannot forward my slides, Tina. There you go. I guess it worked. So my main role in our practice is I am the hepatitis C nurse coordinator, and as we just heard from Dr. Truskin, what a challenge this is for patients and practices involved. But my main role here is, again, I'm the hepatitis C nurse coordinator. I'm actually a resource for the patient, so I kind of act as a patient navigator to try to get them through this very complex process. So prior to us getting medications for patients when they come in for their visit, I sit down with the patients to kind of review what the process is, so they kind of have a realistic time frame of what we're going to be dealing with and what obstacles we're probably going to be approaching based on the severity of their disease or their insurance or what it may be. We also talk about the specialty pharmacies, so they are aware that this isn't going to be coming from the local Walgreens. It will need to come from a specialty pharmacy. They may get a phone call from specialty pharmacies, so they're aware of where the medications are going to be coming from. We also have all our patients come in for an education class prior to starting treatment, and I'll go into a little bit more detail what that entails. It's not that we think patients are fully capable of taking pills. It's really just to make sure that they understand what the length of their treatment is, how long, how many weeks they're going to be on treatment, how are they going to get refills, make sure the authorization is set in place so when they try to go get their next fill, we don't have any surprises. And also to make sure that the patient's copays are okay. They haven't been dealt a big, huge copay from the specialty pharmacies, and also to make sure we have all their lab work and follow-up appointments set up. And I also manage the patients while they're on treatment and also after treatment, and so we can get their lab work done so we can see if they've received an SVR. So similar to what Dr. Truskin talked about, you do need an office infrastructure in order to get through the obstacles of this approval process. So we have a team approach with the provider, the nurse coordinator, and then the medical assistant coordinator, who actually is the one who's really following up with the insurance companies and making sure they received all the clinical information that they needed, and dealing with the denials, depending on what the denial is. If it's stating that they didn't receive certain clinical information, then we follow up with them and refax the information. I'm not going to go too much into detail regarding the process, since Dr. Truskin did an excellent job with that, and it sounds like we're all kind of in the same boat. So the process does start with a prior authorization, and more than likely we'll get a denial depending on, again, if they did not meet the advanced liver disease, or if they didn't have an active or current drug screen, or if their labs are too old, or whatever it may be. For our patients that come in, we actually, if we know they're not going to meet the criteria because of the advanced liver disease, we actually will start the patient assistant program application at that time and just kind of hold on to it until we have the appropriate information from the insurance in regards to the denials. So again, you start with a prior authorization and then you'll get a denial. Sometimes, depending on what the denial is, we submit the HCV guidelines, and I'm sorry, there was a mistypo there. If it's, if they're still requiring that the patient needs to be taking interferon, then we will submit the HCV guidelines along with the appeal. And then it does come back to, we actually are not having to do 2 levels of appeal at this point. We can just do 1 level of appeal. We do go to the medical directors or the PharmDs with our liver providers, and then we also may have to go up to an independent review. As far as the training, so once the patients do get approved and they actually have their medications from the specialty pharmacy, I actually do a group class either in the office or telephonic, because many of our patients are seen in some of our outreach clinics. Sometimes we'll do a telephonic so they're not having to drive 5-6 hours just for their training. But it's set up for a telephonic similar to what we're doing now. And part of the class, we go over, again, the length of their treatment, how they're going to get their medications, how medication storage, side effects, and how to manage them, their lab schedule, their follow-up appointments, abstaining from alcohol or drugs if they can at that point, birth control, and when and how to notify us if there's any problems. We also we go over, how to get in touch with somebody if they need nurse triage, and again, how to manage their side effects. So next, I'm going to talk about a couple case studies that we had that luckily have turned out to be positive, and of course, we have many that we're still fighting for. But we had a 64-year-old patient who was in need of a lung transplant. She actually found out she was hepatitis C when they were doing her lung transplant evaluation labs. She was needing a lung transplant for COPD and emphysema. This was actually back in the Alicio Salvaldi days. She did have a commercial plan. She was denied due to not being FDA approved, so we did an appeal. And the appeal was denied, and at that point we had to do a second level appeal, which we submitted, and again it was denied because it was not FDA approved to be used together. We went to our liver providers actually went to the medical director. The medical director still denied, basically saying they couldn't bend the rules for one patient. So we did do an independent review, and the review was performed by a plastic surgeon, and it was denied. We did go to the patient assistance programs, and she actually was able to obtain free drug through the patient assistance programs, and did complete treatment. And 3 weeks after completing treatment, she actually received her lung transplant. Her lung transplant could not be performed until her hepatitis C was cleared. So this was a very, and as we were trying to get this process taken care of, her lung disease was actually worsening and her oxygen requirements were actually increasing. So it was a very frustrating process, not only for the patient, but also for us as well, and also for the lung transplant department. We were all just running and trying to get her the drug that she needed so we could get her listed for a lung transplant. Luckily, it all worked out in her favor, and like I said, she did get her lung transplant, and she has obtained her SVR, and she's been doing great. The second case I have is a 27-year-old who is on the Arizona Medicaid program. His treatment was denied due to he did not have advanced liver disease. He only had a fibrosis score of 1. So his prior authorization was denied. We did do an appeal, which was also denied. We did apply him to the patient assistance program, and he did get approved pretty quickly. We started this process back in March, and he actually just got his free drug and started treatment a week ago. So luckily, we did have 2 favorable case studies. But like Dr. Truskin mentioned, it is, you do get many roadblocks during this process. And but what I think we need to stress to the community and also to patients is, we just can't give up. We have been able to get almost everybody that we've tried to get treated. We're still in the process of trying to fight that battle. But we really just need to make that message clear that, we just can't give up. We still need to continue fighting this battle.
Excellent. Thank you so much. Our final speaker today is Courtney Jones, who is the Senior Case Management Director for the Patient Advocate Foundation. She is responsible for all aspects of the case management department, ensuring compliance with contractual obligations, quality service levels, and serves as the primary operational point of contact for existing donor partnerships. She monitors trends on various healthcare-related issues and provides information on emerging trends to the Patient Advocate Foundation leadership team. While working collaboratively with PAF executives, she promotes and expands programs that continue to support the mission. Ms. Jones has over 9 years of experience with the Patient Advocate Foundation, serving in multiple roles over the years as Director of Livestrong Partnership, Quality Assurance Coordinator, and Director of Contract Vendor Services. Several of her professional accomplishments include development and expansion of quality assurance standards for over 50 case managers, ensuring the highest level of service and attention to detail. In her role as Director of Contract Vendor Services, she developed work processes designed to increase functionality and efficiency, which resulted in PAF continually exceeding monthly target goals. In previous years, Ms. Jones has served on the PAF Publications Committee and has co-authored several publications which have been produced and copyrighted by the Foundation. She serves as an integral part of the Patient Services Training Program. Welcome, Ms. Jones.
Thank you. Thank you all for attending, and I am happy to start now. I believe I'll just say next slide.
That works.
Okay, thanks. So yeah, if you just go ahead to the next slide. We have a hepatitis C care line here at the Patient Advocate Foundation, and just to give you some understanding and background of our foundation, our mission is to seek to safeguard patients through mediation, assuring access to care, maintenance of employment, and preservation of financial stability for patients relative to their diagnosis consisting of chronic, life-threatening, or debilitating diseases. Our foundation was founded in 1996, and as of this date has provided direct, sustained assistance to more than 740,000 patients and touched millions more through PAF website, online chats, and outreach, nationwide outreach events. If you go to the next slide, please. I just wanted to give you an idea of what my presentation and the agenda that I wish to cover, just to explain PAF as a whole, and then focus on our hepatitis C care line overview, the entry points of referring a case over to our care line, as well as the process once a case is received. I'm going to highlight our copay relief program, as well as some case studies that have been recent with patients we have assisted. Next slide. Our case management services, PAF has had for over 19 years. We help with prior authorization approvals, coding billing errors, assistance with expediting assistance applications such as Social Security, Disability, and Medicaid. We assist with debt crisis resolutions, and those are mainly around copay-related issues or general living expenses, where patients have to make a decision on whether or not to pay for their prescription coverage or their therapy prescribed, or make sure they have food on the table and a roof over their head. We help with in-depth appeals assistance, clinical trials education, patient education, just a basic understanding of terminology used, insurance coverage, and we do have collection of real-time data and outcomes reporting. Next slide. Since 2014, we have impacted over 88,962 patients just in 2014 that have received direct sustained assistance, which leads to over 1 million contacts made on behalf of patients to resolve their issues that they are calling for. And those that have called PAF, 59.4% of them have called related to medical debt. Next slide. I just wanted to give you an overview of our cases that Patient Advocate Foundation handles and some of our top patient issues that we saw in 2014. Our debt crisis cost of living was over 25%. Then our insurance was second at 19%. And then we found the third highest at 13% being uninsured, with medical copay coming in to fourth. I just think this is good to show the patients and what they're calling our assistance lines for, so you can see the issues that patient populations are facing. Next slide, excuse me. This just shows you our debt relief obtained. I think this is important when we highlight our services and what we offer and how positive our resolutions are with assisting the patients. So we look at the cases that we help and the resolutions that we achieve, and if we were able to overturn an appeal and save the patient the out-of-pocket costs, if we were able to find the patient a copay assistance program or any other financial relief, and tracking that financial relief that the patients are able to have seen, as well as a provider once we overturn an appeal, that is not now an account on their books that they are now trying to collect for a patient. Next slide. We get into now our hepatitis C care line overview. We have launched our hepatitis C care line on January 5th of this year. We are staffed by a team of seasoned case managers who actually provide individualized case services to hepatitis C patients, caregivers, and providers. So once you are assigned a case manager, that case manager will work your case till the resolution. And the focus of our hepatitis C care line is access to care issues, which are lack of coverage resulting in no access to care, the inability to afford the medical or pharmaceutical copays or coinsurance, and lack of access to the required health care. There may be a cost barrier, transportation barrier, or coverage denials. We also assist the patients with insurance denials, and those are mainly due to out-of-network benefits, benefit exclusions, off-label, experimental, investigational denials, and then other patient assistance services that are not directly related to their needs but still beneficial, such as applying for Social Security, disability, and educating on FMLA and ADA accommodations. Next slide. We do have a one-pager that if anybody would like to see that I can forward to you. It is used as a training tool for our case managers and copay relief counselors, and it is provided to an external resource organizations as a referral guide on how to refer patients to our hepatitis C care line. We have posted it on our PAS social media site, so some of you may see it if you have followed our Facebook or other social media avenues, but it explains our services in a one page, a way to reach our care line as well as our hours of operation, which are 8 a.m. to 8 p.m. Eastern Standard Time, Monday through Thursday, and 8 a.m. to 7 p.m. Eastern Standard Time on Friday. Next slide. So in order to refer a patient, or if you are a patient, to refer yourself over to our hepatitis C care line, we do have a dedicated toll-free number, which is 1-800-532-5274. So you press option 2 to reach a case manager, to reach our case management services, then option 3, and then you'll be directed through prompts, and then you would select the one connected to the hepatitis C care line. The way that we are able to receive referrals is you will initially talk to a live medical intake specialist who would be able to gather information such as your demographics as well as the issue that you are seeking assistance with. Once that information is obtained, the patients will be assigned and connected to a case manager within 48 to 72 hours to have a return call back, and then the case manager will reach out to who that designated point of contact is. Sometimes it may be the provider, sometimes it may be a caregiver or the patient themselves, and they will start working the case to resolve the issue that is presented. And our case manager works the case to actual resolution. So and we do have a hepatitis C directed website as well, which was on that slide. Now I'm going to speak a little bit about our copay relief program. That was our case management services we discussed earlier, and we also do have a copay relief program as well. If you go to the next slide. Our copay relief program will have completed 11 years of service in April 2015. We've served over 102,000 patients between 2004 and 2014, and we've allocated more than $232 million in patient assistance, which is mobilizing insurance reimbursement of approximately $1.16 billion. Next slide. The eligibility criteria for copay relief is household income of 400% or less of the federal poverty guidelines, and it is adjusted for cost of living index depending on the state that you currently reside in. You do have to have a verified qualifying diagnosis, and hepatitis C is one of the qualifying diagnoses, and insurance coverage that currently includes pharmaceutical coverage. Next slide. Our patient approval and award management, we have changed our model a little bit right now so that we are actually providing an award decision immediately. So if a patient calls in to apply to copay relief, they will find out at the time of application whether or not they have been approved or denied. And then once they have found out if they are approved, their full award is available at the moment of the approval decision. We do have to have a diagnosis verified by the physician, but our copay relief staff member will be faxing a verification document over to the physician to verify, so that relieves the patient of any obstacle or barrier that they may have on obtaining this document. The award is for a rolling 12-month period from the date of approval, so you have 12 months to utilize the award that you receive. There is a look-back period of 6 months. So if you are currently applying today and you do have some outstanding bills from previous months, if it falls within the 6-month period, you are able to submit for payment of those bills as well. And at the end of your award, there is a 2-month grace period to allow for submittal of the claims based after insurance has made a decision. There is a 120-day utilization requirement, meaning between 120 days, if there is no activity on the grant, that grant is forfeited. So we usually try to inform patients to please, or providers, to stay on top of submitting the claims so they don't fall underneath that 120-day mark. Claims are processed continuously with payment going out every 24 to 48 hours. Patients or providers have the options of receiving a paper check or an EFT transaction, but approximately 90% of all claims are paid directly to a pharmacy or provider. We have a high provider utilization with specialty pharmacies and providers' offices submitting for pharmaceutical copays. Next slide. These are a slide of our available disease funds through our copay relief program, and as you can see right now, the Hepatitis C fund is at a $10,000 cap. We do also have a Hepatitis B fund at $4,000 right now as well. Next slide. Oh, you've got to advance along. It's a fancy slide with things coming in. Sorry. We do have national resource directories that we usually also promote through our social media sites, as well as forwarding to providers' offices and patients, that we have them for the uninsured, the underinsured, and just a financial site that provides links to organizations that offer financial assistance as well as educational tools. So if there are patients that also are very savvy on the computer or phone apps that wish to be able to search this information themselves, social workers are heavy in using this information as well in some navigators and providers' offices to be able just to have hands-on and enter some patient data information. And it does go specific to nationwide, stay specific to state or to city if that's what you're looking for national or local resources to help offset costs such as living expenses, other copay-related organizations, and educational opportunities if they want some additional information on Medicare, Medicaid, and such. Next slide. We do also have a myriad of patient education that explains a lot of questions that we get from patients to understanding how to read an explanation of benefits, understanding how to write an appeal if they wish to write the appeals themselves, or just even understanding the appeals process, as well as the guide to the disability process, applying for disability, appealing disability denial. What does it mean when they say I'm denied for XYZ reason? Understanding healthcare reform, Medicare. We have a myriad of those. They are available for download on our website or able to be ordered and mailed as well. Next slide. I wanted to give a case example. We helped a 53-year-old male diagnosed with hepatitis C. His insurance company denied the request for Harvoni, stating he did not meet the medical criteria for the prescribed therapy. Our PIF case manager was able to obtain the medical documentation working with the provider and submitted the insurance appeal on behalf of the patient. Our insurance denial was overturned, and the patient was approved for the 12-week treatment course of Harvoni. And the PIF case manager was able to continue to assist the patient by gaining approval for our copay assistance program to help with the high copay costs associated with the therapy. So that just shows you that we were able to help through the denial process as well as the copay to know that once the denial was overturned, there was still a financial barrier that the patient faced in obtaining the therapy. If you go to the next slide. The next is a 63-year-old male diagnosed with hepatitis C and cutaneous T-cell lymphoma. The insurance company again denied the request for Harvoni, stating his disease had not progressed enough to meet the medical criteria for the prescribed therapy. Again, the PF case manager worked to obtain medical documentation from the provider to substantiate the reason for the prescribed therapy and was able to submit the insurance appeal on behalf of the patient. We assisted the patient in applying for other patient assistance programs to which he was approved and was able to start his treatment. And usually our appeals process at times can take anywhere from 30 to 45 days from the case being referred to resolution. We have been receiving a high volume of appeals based on the prescribed therapy, and we've since starting and launching our program in January 5th of 2015, we've averaged 80 cases a month. So year to date, at the end of May, it's been about 384 cases. And when I pull some statistics just to see the number of contacts it takes to resolve a case, and this is reaching out to the provider, the patient, the insurance company, is averaging between 22 to 25 contacts to bring the case to resolution. So we are very successful in resolving these cases fairly quickly and not having to have them drag on so long. And we do have other copay assistance programs that we're aware of that we also help apply for. So at times it's making sure that they can obtain the 1-month therapy and then moving into if there's another copay for their next therapy that comes. Next page. This is where I opened up for questions. If you go to the next page, that's our contact information. So if there's any questions or any other thoughts that you have in regards to our services, I just wanted to make sure that I provided my contact information to be able to reach out and ask any of the questions that you may have.
Excellent. Thank you so much. And thank you again to all of the panelists, not only for sharing such great information and resources, but for inspiring and giving some hope of what can be done when a medical or health or social service provider is an advocate on behalf of your patients and your clients. It's great to know that this kind of work is going out there, and I'm sure you've given a lot of information and inspiration to a lot of people on the line. So we're running a little bit short on Q&A time. I want to thank everybody for bearing with us with a few of the technical difficulties, but we do have some time. I'm going to turn it over to Tina Broder to see if any questions have come through. And just as a reminder, you can submit questions to the questions box on your in the webinar, or you can send an email to tbroder@nvhr.org. Also, if we get questions after the webinar finishes, we will certainly get the answers from our panelists and get back to you. Tina?
Hi, everyone. So I've had a couple of questions about technical issues, which I think have all been resolved, and we're waiting for your questions now. So if anyone has, we have time probably for 1 or 2 questions, or in the meantime, if any of the panelists have questions for each other. Okay. So we have a question. Were the questions that Stacey presented typical cases or sort of worst case scenario examples?
Hi, those are typical. Those are typical. I tried to give a representation of some of the patients who were able to get medication through, and some who we had even greater challenges with. It's a rare patient, but they do happen that are very straightforward. I think it's easiest. We have great victory stories from Medicare. Medicare is very easy to work with, and most patients that we apply with, we were able to get it through on the first or second time, and usually about a 4 to 6 week turnaround time. So I would say that those are the cases I presented today. Some were private and mostly were Medicaid, but Medicare is a joy to work with.
We had a question about slides, so I'll just reiterate that everyone who registered for this webinar will receive a copy of the slides and recording, and they'll also be posted on our website. So another question we have is, do you sometimes lose patients while they're going through this month-long process of seeking approvals, and what strategies do you use to maintain them?
Do you want me to answer that? That's Karen.
Sure.
Or does Dr. Truska want to answer it?
You can go ahead, Karen. I can follow up after.
Okay. So, you know, we actually don't lose patients just because we are constantly kind of keeping them in the loop. So they know that, you know, we're still pushing forward. But we actually haven't really lost a patient just because, you know, especially when you're starting to apply them to the patient assistance programs, you know, you need some information from them in order to apply them to the program. So we do keep them in the loop as we're, you know, telling them we're going through the denials and the appeals and so forth. So we actually haven't lost a patient.
What barriers have you seen for navigators and other providers in reaching resolution?
Say that again. I'm sorry.
What barriers have you seen for navigators and other providers in reaching resolution?
In reaching resolution of obtaining the treatment?
That's what I'm guessing.
I guess I don't understand this question.
I think the question is just, you know, what kind of maybe barriers any additional barriers you've seen trying to reach resolution for your clients or your patients?
Well, unfortunately, especially with some of the Medicaid plans, they're constantly changing their rules. So just when you think you have it all figured out, then they come with a new rule that, the labs have to be less than 30 days. So, again, you just have to, I think it all comes down to really educating the patients and, some of those barriers you don't have control over, that they're going to change their rules. But you just, you got to kind of appease their needs so that you can either get the medication from them or, try to go through the patient assistance program. It's very frustrating because just when you think you have it all figured out, then they change the rules.
And we had a question on how different the treatment is for Hep C and HIV, and I know that's hard to do in 30 seconds, so I don't know if any of you could point to a specific resource that would be good for someone to review.
I can try to take that. This is Stacy. I think the simplest difference is that Hep C treatment is curative, and we don't yet have a cure for HIV. I think that in terms of the burden of pills, we're pretty much looking at the same thing now. We have fixed dose combination pills for both medications, but really it's the finality of the Hep C medications. And if anybody's interested in looking at the guidance for treating patients with hepatitis C, I would encourage them to look at www.hcvguidelines.org.
Excellent, thank you. This is Ryan again, and we've come at the end of the hour. I want to once again thank our panelists for sharing their insights and strategies, and for everyone who was on the webinar. If you had a question that did not get answered, or if you come up with a question, please email it to us. Probably the easiest way would be info@nvhr.org, and we will get that, that question answered by our panelists and get that back to you. And once again, we will be sending out slides and an archive of the recording to everybody who registered, and it will be up on our website shortly. So thank you again, and have a great day, everyone.
Thank you.